treatment. The objectives, BLS, we're going to discuss 12-lead applications, BLS monitor operations, BLS treatment for tachycardia, and medications applicable to a BLS provider. ALS, we're going to cover monitor operations, review different rhythms for bradycardia and tachycardia, discuss medications applicable to bradycardia and tachycardia, and review electric therapy for adults and pediatric patients. 12-lead application. To start the 4-lead, the further away you put each lead on the limbs, the better picture it's going to take of your heart. But traditionally, we're putting them on the left and right shoulders each and on the lower portion of the abdomen. V1 and V2 are going to be placed at the 4th intercostal space on either side of the sternum. V4 is going to be placed mid-clavicular, 5th intercostal space. V6 is going to be placed mid-axillary, level with V4. V3 is going to be placed directly between leads V2 and V4 in a straight line, and then V5 is going to be placed in a straight line between V4 and V6. So we're going to be straight across the middle of the chest, a straight diagonal down between V2 and V4, and then another straight line from V4 to V6. BLS monitor operations. The BLS provider should know where the pads go in the upper right shoulder of the patient, as well as below the left armpit. Preferred placement, though, is going to be anterior, posterior over the heart, so the front and the back. Lead placements discussed above. The SBO2 should be placed on the non-dominant hand on the ring finger. Blood pressure cuff, be sure to have the appropriate size, applied tight enough, also applied level so that the Velcro doesn't meet at a next pattern. And be sure to practice manual blood pressures too. And Tidal CO2, make sure you plug it into the left side of the monitor, as well as pressing the activation button on the front screen of the monitor, and then hook up the oxygen also. ALS monitor operations, we can show a picture there of the dual sequential pad placement or the first or second options for placing pads. You can pace with the monitor, defibrillate, sync cardiovert, and then as well as sedation. Bradycardic rhythms, the definition of the critical or severe bradycardia rhythms in our SOP book is moderate to severe cardiorespiratory compromise, decompensated state, progressive instability, slow heart rate below 60, SBP, systolic blood pressure below 90, acute AMS, chest discomfort or pain, shortness of breath, poor peripheral perfusion, weakness, fatigue, lightheaded, dizzy, syncope or pre-syncope, pulmonary congestion, heart failure, or pulmonary edema, escape beats, or frequent PVCs. They require emergent therapy to avert progressive full arrest. The heart rate is going to be below 60. That's what's going to be defined as bradycardia. Sinus brady is going to be a rate below 60, as with all of the other ones. The P wave is existent with the QRS. PR interval is going to be under 0.20, and there's going to be a T wave as well. It's a sinus rhythm, just slow. The junctional rhythm originates in the AV node. It can make a few different types of P waves due to that, either hidden, inverted, or after the QRS. They appear to be hidden because they happen at the same time as the QRS, so they're hidden under that. They could be inverted, again, because of the pathway they take back to the SA node, or they could be after the QRS because of the timing it takes for them to get back to the top of the heart. Here are 3 examples of that. First degree AV block looks similar to a sinus rhythm, but the PR interval is prolonged. It's going to be over that 0.20. Second degree AV block type 1, otherwise known as a Winky block. The PR interval gets longer and longer until a QRS is dropped. As you can see with the first 3 rhythms, the PR interval is growing and growing until the QRS is dropped, and then it resets itself. Again, growing and growing for the PR interval, and QRS is dropped. Second degree AV block type 2, the PR interval is consistent, the QRS is dropped. So P waves, PR interval, and a QRS for the most part are regular and consistent. but there is one P wave that drops a QRS because the signal fails to go through the AV node. Third degree AV block. P waves march out on their own respectively. The PR intervals are all irregular. QRS also marches out on its own interval respectively. So independently, the P waves and the QRSs are regular, but when you mix them together in one organized rhythm, they're very irregular. Idioventricular is defined as relating to or affecting the cardiac ventricles alone. Idioventricular is a slow version of VTAC. It is defined as VTAC when it is over 120. This is kind of your heart's last-ditch effort before arrest. Bradycardia treatments, there's the list. We'll go over those respectively. Saline, provided to keep hemodynamic stability, so your blood pressure above 90 and keep your volume within your vessels. We provide atropine. It is an anticholinergic. It is a parasympathetic blocker. Indirectly raises your heart rate in AV conduction. We provide 0.5 milligram rapid IV push for adults every 3 to 5 minutes. For pediatric patients, we provide 0.02 milligram per kilogram, minimum of 0.1 milligram doses. The max child dose for a single dose is 0.5. Max total dose for a child is 1 milligram. And the max dose single for an adolescent is 1 milligram. Max total dose is 2 milligrams. Dopamine is endogenous catecholamine. Sympathetic nervous system antagonist, stimulates the beta-1 and alpha receptors. Our beta dose is the first dose we start at, the 5 microgram per kilogram per minute dose. That is going to raise your heart rate, stroke volume, contractility, systolic blood pressure, cardiac output, and renal blood flow. And then you move up to the alpha dose, which is the 10 microgram per kilogram per minute. May titrate up to 20 microgram per kilogram per minute to maintain your systolic blood pressure above 90 or an acceptable PEDS blood pressure within the limits. The alpha dose is going to be all of the above plus vasoconstriction, raising your preload, your afterload, your blood pressure, and lowering your renal blood flow. Midazolam, or Versed, or fentanyl and ketamine. Midazolam for sedation. We'll provide this if we're going to be pacing the patient. Sedation dose for pacing is 2 milligrams. Fentanyl for pain is 1 microgram, unless it's going to be the 0.5 microgram for an elderly. And then your dose for ketamine is 0.3 milligram per kilogram for pain. Glucagon is a hormone, cardiac stimulant. It's a positive inotrope. Causes release of catecholamines and stimulates the C-amp in cells to raise cardiac output. We provide 1 milligram for bradycardia if the patient is on beta blockers and medications aren't responding. Aspirin and nitro. Aspirin is an antiplatelet, prevents platelet aggregation, blocks the formation of thromboxane A2, and makes your platelets less likely to coagulate and go together. Organic nitrate is a vasodilating agent. The doses for aspirin is 324 milligrams and nitro is 0.4 milligram. Nitro is contraindicated if your pulse rate is under 50, so we can provide this to some bradycardic patients, but not all. Further bradycardia treatment is pacing. We pace between 60 and 70 beats per minute, depending on what the patient needs. When you click over to the pacer in the monitor, it starts at 30 milliamps. You can range down to 10 and up to 140. And we're trying to find mechanical and electrical capture. So when you see a pacer spike and then a QRS, you want to make sure that the patient has a pulse. Cover some of the tachycardia rhythms. Tachycardia, defined in the SOP book, is severe cardiorespiratory perfusion compromise, heart rate over 150, altered mental status, systolic blood pressure below 90, shortness of breath, ongoing chest pain, shock, pulmonary edema, heart failure, or ACS. Immediate cardioversion is seldom needed for the patient's heart rate. SVT, supraventricular tachycardia. It originates above the AV node. The starting point for beats per minute for an adult is 150 to separate sinus tach from SVT, and for a child is 180. It is at the speed fast enough that it may be covering up P waves, so they may still exist, but without slowing it down to look, we just define it as SVT. Ventricular tachycardia, I gave you a few different options for things that are ventricular tachycardia or VTAC. Although they are all still VTAC, they still appear different. Originates in the ventricles, can have a pulse, and again, it's a tachycardic rhythm. Torsades de pointes, it's a polymorphic ventricular tachycardia, comes from different points in the ventricles, creating a twisting pattern. Atrial fibrillation with an RVR, a rapid ventricular response. It's like AFib, only faster. It is an irregular rhythm. If the rhythm is going too fast, it may look regular, providing medications to slow it down to the point that you can see if it is sinus or it is AFib. Aberrancy and SVT, I did have to look this one up to refresh myself with what this was. To begin, all wide complex tachycardia should be considered VTAC until proven otherwise. A rhythm like this is the reason that we can provide Bradycardia under the VTAC protocol. It's a wide complex tachycardic rhythm. Causes include tachycardia with a right or left bundle branch block. When rhythm is fast, it looks similar to VTAC. When it's slowed down, it can be interpreted appropriately as a bundle branch block. Created when a supraventricular rhythm is abnormally conducted through the ventricular conducting system, creating a wide QRS. Irregular wide complex tachycardia. Think AFib with aberrancy, just like the last slide. Tachycardia treatments that we can cover. The vagal maneuvers. It's a BLS treatment. You can have them blow on their thumb or into an angio or into a syringe, as the guy in the picture is doing. We provide saline, provided to keep hemodynamic stability. We can provide fluid boluses. Adenosine, it's an antiarrhythmic, slows or blocks conduction through the AV node, interrupts AV reentry pathways. We provide 6 milligram or 12 milligram, followed by a 10 ml flush rapid. And for the pediatric patients, it is 0.1 or 0.2 milligram per kilogram doses. Verapamil. Sorry.
Diabetic problem. 1271 Muriel Street, 453. Do Woodstock.
It's a calcium channel blocker. It slows depolarization of slow channel electrical cells. Slows conduction through AV node. Yeah?
We gotta go.
Okay.
That's like right around the corner here. That's a long way for 53 to go.
The calcium channel blocker slows depolarization of slow channel electrical cells, slows conduction through the AV node to control ventricular rate associated with rapid atrial rhythms, relaxes smooth muscle, dilates coronary arteries, lowers afterload, and myocardial contractility. We provide 5 milligrams over 2 minutes, 3 minutes for elderly. Can repeat dose in 15 minutes. Amiodarone, it's an antidysrhythmic, predominantly class 3 properties of all 4 Vaughan-Williams classes. Delays repolarization, prolonging action potential, slows AV conduction, prolongs AV refractory period and QT interval, slows ventricular conduction, widens QRS, blocks sodium, potassium, calcium channels, and alpha-beta receptors. Negative chronotropic and dromotropic effects, vasodilates, meaning lower cardiac workload and myocardial O2 consumption. Adults with VTAC, with a pulse, get 150 milligram with 7 ml saline slow IV push over 10 minutes. So 10 mLs total with 3 mLs of the drug and 7 mLs of saline. Can also hang a bag of 100 ml saline over 10 minutes. Please remember, if you hang a bag of 50 or 100 ml saline, pay attention to the secondary IV tubing size. You may need to calculate drip rate depending on the volume of saline, as well as whether you have 10 drop, 15 drop, or second drop secondary tubing. PEDS dose is 5 milligram per kilogram mixed into total volume of 20 ml saline, or the 50 or 100 ml bag, still over 10 minutes. Magnesium, it's an intracellular cation responsible for metabolic processes and enzymatic reactions, critical in glycolysis, needed for ATP production. Membrane stabilizer, blocks neuromuscular transmission and muscular excitability. Class 5 antidysrhythmic, acts like a calcium channel blocker, causes smooth muscle relaxation, vaso and bronchodilator. We provide 2 grams or 4 ml vials mixed into 16 mLs of saline, pushed over 5 to 10 minutes. Can also hang the 50 ml bag over 5 to 10 minutes. Maximum dose is 1 gram per minute in an adult. Again, pay attention to the tubing size for your drip rates. And for the PEDS dose, it is 25 milligram per kilogram mixed into a total volume of 20 ml saline over 10 minutes. Maximum is 1 gram in 5 minutes. Aspirin nitro, it's the same as bradycardia. It's a 324 milligram, 0.4 milligram tablet of nitro. It's contraindicated though, this time if the pulse rate is over 100 for the nitro. Tachycardia treatment. Maybe some of you know the Ramones song, Gimme Gimme Shock Treatment. We defibrillate and sync cardiovert. As you can see, the patient on the right is being defibrillated. For tachycardia treatment for defibrillation, we can defibrillate torsades at 120, 150, and 200 joules respectively. And we can sync cardiovert, all of the other tachycardic rhythms besides torsades. We would start at 70 joules for PSVT and A flutter. They respond to lower joule rates, so we'll try that first. Then you move up to 120, 150, and 200 respectively. Thank you.